Hello, and welcome to another Journeys with Jim. That's right, today we're going to be talking about the GI tract. It's one of my most favorite systems in the body, for obvious reasons. But it's the immense proportions of, no pun intended, of this system at times really kind of trip people up as they're understanding the concept of elimination, of digestion and elimination. So today we're going to talk about from front to back, all the way through, and how the GI system functions and some of the disease processes that go along with this system. I hope you are just as excited as I am to get started. And for our video today, I want you to kind of understand that what the window represents is the mouth, and what the patio door represents is the rectum, the anus. See, there it is, it's outside. Alright, so first off, you need to understand that the segments of the GI tract are broken down into, you've got your mouth, you've got the esophagus, which is only about a foot long, and then you've got your stomach, which is going to be just down slightly from there, is about a foot long. Then you have your duodenum, which is going to be about a foot long. And then you have your jejunum, which is going to be about 8 feet long. And then you have your ileum, that's going to be about 10 feet long. And then your colon is going to be about 5 feet long. And your sigmoid colon and rectum are going to be about a foot long. And so it totals up to be about 27 feet. So if I take this super bouncy ball or marble or a piece of corn that you don't chew up quite right, and I were to drop that into the mouth that's outside of the body. We all understand that. The mouth is outside the body. Here it goes. Okay? Little red marble, little white marble, whatever it may be, in the mouth it goes. That's outside the body. What I want you to realize is that marble, that piece of food, whatever it is that you swallowed, is technically not inside of the body, because this house is the body. This garden hose is our intestine, is our GI tract. And so that piece of food that's going through the mouth, into the esophagus, it's going to go into the stomach, it's going to pass through different sphincters as it travels along the way. Food is going to engage the musculature of the body, and it's a part of mechanical digestion. And essentially what it is if I were to walk along this garden hose, okay, you can even hear it's kind of crunchy, okay, that the intestines are squeezing around that food, that bolus of food, the chyme, as it's mixing in with all the intestinal secretions, and we're going to talk about that in a little bit, but this is peristalsis. I'm moving it along, I'm moving it along, I'm moving it along, and out comes, where'd it go? There it is, there's my white marble. Alright, so out it comes the back end. Alright, so I just gave you an idea of what happens when food enters the mouth, travels through the GI tract, and then in fact that food is still outside of the body until it's absorbed in through the intestinal mucosa. That's why when you eat corn and don't chew it up right, it comes out as corn. Or if you were to swallow a marble, it would come out as a marble. It's not getting absorbed into the body, into the house. Okay? So food that goes in the mouth travels through the esophagus first and hits its first sphincter. Okay? Its first sphincter, upper and lower esophageal sphincters, keep the pressure and keep the food located where it needs to be, and that's in the stomach. Gravity and peristalsis takes the food down through the esophagus, and then into the stomach. But if you eat too much, too fast, carbonated, highly acidic, you might build up pressure in your stomach that it wasn't intended to hold. And as you wear on that lower esophageal sphincter can no longer hold that pressure, hold those gases and the food inside of the stomach. And it's going to weaken and maybe even erode a little bit as the acidity builds up. And it's going to open up, and food is going to come up into the esophagus, and that's where you get that irpy feeling, or that, oh, I just threw open my mouth a little bit. Okay, that food comes back up, and that's because of that lower esophageal sphincter. If you go down a little bit farther into the stomach, which again is about a foot in length, some curvature, holds onto the food, starts some of the digestion processes, which, by the way, sugars are first broken down by salivary amylase, okay, and that's a parasympathetic function that if we're under normal daily life issues, we're not under threat of any attack, our salivary glands are going to secrete more saliva because that's a normal process. But if we come under fight or flight, the sympathetic nervous system, those salivary glands are going to shut down. So normal daily functioning, salivary glands are going to secrete saliva to help break down foods, and they first start breaking down the sugars. Then food gets into the esophagus, into the stomach, and proteins are starting to be broken down in the stomach. Okay, and with that, in the stomach, you have all that acidity. And that's one way that we test that maybe an NG is placed in the right location, is we do that pH test. There's a lot of different problems that can go on. You can get cancer of the stomach, GERD, and peptic ulcer disease is another big issue with the GI tract. And so you can have peptic ulcer disease in the stomach, or just beyond, okay, if this is the pyloric sphincter, just beyond that sphincter is the duodenum. And the duodenum is only about a foot long, okay, but you can get peptic ulcer disease in the stomach, and you can get it in the duodenum. One of the high likelihoods of peptic ulcer disease formation is things like H. pylori, cigarette smoking, drinking, stuff like that. It's and high acidic foods, things like that are going to eat away and add more acid to the system. Also things that cut down on the mucus production, like NSAID use, aspirin, Motrin, chronic use. These NSAIDs are non-steroidal anti-inflammatory drugs, but they also shut down some of the prostaglandin and mucus lining production, and so you have issues with thinning out that mucus layer, which protects the stomach mucosa, the lining, from the actual acid. So that's a problem. Then you get into the duodenum. Maybe that pyloric sphincter opens up as the food travels through, and you have proper functioning. But if that pyloric sphincter shuts down, then or has stenosis, it hardens, it doesn't open up the proper way, there's only one location that food can go. So as you keep eating, food's not getting through where it needs to get through in the GI tract, and it comes back out. Vomiting is a big issue, one of the indicators that you might be having issues with your pyloric sphincter. As you travel past the pyloric sphincter, you get into the duodenum, and in the duodenum, that's where your pancreatic enzymes are secreted and released into that part of the GI tract, and the pancreatic secretions break down all kinds of foods, literally. Fats, carbs, proteins, alcohol, and one of the big issues with pancreatitis is alcohol use, chronic alcohol use, because it causes a lot of pancreatic enzymes to be secreted chronically, more so than it wants to handle, and so you end up with pancreatitis from alcohol use. Then you have, and the duodenum starts to break down, again, all those different parts of foods, and the food starts to be digested and then absorbed, okay? So now it's being absorbed in through the intestinal mucosa, the ileum, the jejunum, the ileum, and again, the jejunum is about 8 feet long, and the ileum is about 10 feet long, and then your Cecum and colon are about 5 feet long, and then another foot or so at the back end. So as the jejunum helps to peristall, break down that food, absorb that food through the intestinal mucosa, all those foods, all those particles go to the liver. And again, the liver is a big part of the GI tract in the process of absorbing and metabolizing the food that we take in. With the liver, you want to obviously still eat balanced meals, but when you drink too much, alcohol use is a big issue with the liver, and it causes liver cirrhosis, and that liver cirrhosis can then lead to portal hypertension, which causes this blockage back into the portal vein, all right? And with that, you end up with things like esophageal varices, which goes because that's part of the blood, the vascular system that feeds the esophagus, and it adds pressure to the esophageal vasculature, which causes these little mini ruptures, bleeding into the esophagus. And we'll talk about GI bleeding in just a little bit. But that's an issue with the liver and with cirrhosis and portal hypertension. So you keep moving on, and then you get to, you get through the duodenum, the jejunum, the ileum, and you get to another valve. I'm going to keep pulling this up here. All right, we get to another valve. All right, and that's the ileocecal valve. That's where the ileum connects with the cecum, which is the very beginning structure of the large intestine, the colon. It's also the ileocecal area. The cecum is where the appendix is located. We know about the appendix and appendicitis and rebound tenderness and lots of pain with it, and you end up with surgery and you're fine. The issue is if that ruptures before you go to surgery or during the surgical process, peritonitis can take you out. It can kill you because of the infection. You're leaking all those gastric juices into the abdominal cavity, just into the kitchen, into the dining room. There it is. It just, the rupture in the wall and all this leakage out, and that has to be cleaned up, which isn't any fun, whether it's figuratively or literally speaking with the body or the house. So you got that ileocecal valve. Again, if you have issues with that valve or obstructions along the way, tumors, food blockage, maybe the intestine musculature stops functioning, and so you have the stoppage of this food. You get that obstruction in there. It's going to cause discomfort, distension. It might back up to cause vomiting as well. Different symptoms are going to occur with blockages. You keep going through the colon. The colon is going to help absorb water and more of the food particles that we don't want to see excreted. So it's going to pull that water in and any leftover things the body wants to pull in. And what's left behind ends up being the stool. Okay, the colon finishes off and then out the back door. Alright, so I want to finish off this video with just a few words about GI bleeds. You can have bleeding throughout the entire GI tract. You could have it in the esophagus. You could have it in the stomach. You could have it in the small intestine, the large intestine, the rectum, the anus, okay? Wherever that bleed is located is going to determine the kind of symptom or sign that's going to be felt or seen by the nurse, by the patient, okay? So if you have bleeding up high, up by the mouth, okay, obviously you're going to spit up blood. It's going to be red. It hasn't been processed at all. If it tracks down in through the esophagus, you have esophageal varices, that kind of bleeding, then if you end up spitting it up, again, it's going to be bright red. If it enters into the stomach and it starts being processed by the stomach, then it starts to change colors if we end up bringing that back up, or if we end up vomiting that back up. And it's called coffee ground emesis. They're black chunks, and sorry about the visual image, but that's really what it looks like. That's why we call it coffee ground emesis. On the other end, if you have bleeding in the esophagus or the stomach or the upper GI tract, the duodenum, the stomach, the esophagus, that's going to be processed for a really long time as it tracks down the GI tract, okay, through the small intestine, through the large intestine, out the back door, out the rectum, out the anus, okay. Because it's been processed for so long in the system, it comes out black and tarry, okay. It's been absorbed and broken down and processed, and so that blood comes out black and tarry. The closer you get to the exit, whether the front or the back, is going to mean that blood, that bleed is going to present more bright and red, okay? So if you have a rectal bleed or an anal fissure or something like that right at the back door, then you're going to end up having bright red blood, okay? You'll see that in the toilet, you'll see that on the tissue paper, okay? But if you have, again, like esophageal varices, or you have GI bleed, the stomach ulcer bleed, or something like that, it's going to present black and tarry. So that's kind of some of the issues that you're going to see with the GI bleeds. I just want to say thank you for joining me on another Journeys with Jim. I hope this has been a beneficial video for you to help you understand the GI tract, the process of food going in, processing through the body, and then leaving. And to that I say ta-ta and toot-toot. Have a nice day.